Welcome to the LACNETS podcast. I'm your host, Lisa Yen. I'm the LACNETS Director of Programs and Outreach, as well as a caregiver and advocate for my husband who is living with NET. In each podcast episode, we talk to a NET expert who answers your top 10 questions. This podcast is for educational purposes only and does not constitute medical advice. Please discuss your questions and concerns with your physician. Thank you for joining us for today's episode of the LACNETS podcast. I'm pleased to introduce our featured speaker for today, Dr. Jaydira Del Rivero. Dr. Del Rivero is the endocrine oncologist at the National Cancer Institute at the NIH. Dr. Del Rivero is board certified in both endocrinology and oncology, and as we know, neuroendocrine tumors, and in particular, paragangliomas and pheochromocytomas involve both these disciplines of endocrinology and oncology. So she's able to bring together both perspectives in her research and clinical care, and we're very grateful for that. Dr. Del Rivero's current efforts is the development of novel treatment approaches and targeted therapies for endocrine malignancies such as advanced gastroenteropancreatic neuroendocrine tumors, adrenocortical cancer, and pheochromocytoma and paraganglioma. Dr. Del Rivero serves on the board of directors for NANETS, the North American Neuroendocrine Tumor Society, which is the NET professional medical organization that we would like our doctors to be on so that they can network with others in the NET field. And she serves as the NANETS Guidelines Committee co-chair and is one of the authors of the NANETS Consensus Guidelines for the surveillance and management of metastatic and or unresectable pheochromocytoma and paraganglioma. Last, but certainly not least, Dr. Del Rivero is a dear friend of LACNETS, and she serves on our newly formed Medical Advisory Council. So we're glad to have her as part of the family. Thank you for joining us again on our LACNETS podcast.
Thank you so much, Lisa and LACNETS, for giving me this opportunity to talk to you all about pheochromocytomas and paragangliomas. As you said, this is something that is very dear to my heart and something that as part of our efforts at the National Cancer Institute, we also try to develop better therapies and more therapies for pheochromocytomas and paragangliomas. And we are fortunate here at the NIH that we have a well-known endocrinologist, Dr. Carl Patza, who is a world expert on pheochromocytomas and paragangliomas. We work very closely together, and we also have treatment studies for pheochromocytomas and paragangliomas, and as well other neuroendocrine tumors. So thank you so much for having me today. I'm very excited to be here today with you all, and I hope all of the questions and answers here are useful to our pheochromocytomas and paragangliomas community. LACNETS is also an organization very dear to my heart, just because of all of the efforts that you're doing to educate our patients with neuroendocrine tumors. So thank you and I'm really grateful to be here with you today.
Well, we're excited to have you, and thank you for your dedication. Just out of curiosity, how did you get interested in not only the rare disease of NET, but in a rare subset of a rare disease?
Right. Thank you so much. Yes, when I was, as you say earlier, I am board certified in endocrinology and oncology. When I first did my endocrinology fellowship, and when I started my endocrinology fellowship, I worked very closely with Dr. Patzak here at the NIH, and I started learning about pheochromocytomas and paragangliomas during my fellowship. Then I practiced as an endocrinologist in New York City under the guidance of Steve Liwoody, who is also well known in the neuroendocrine tumor field. And at that time, we were building the endocrine oncology program as part of Albert Einstein. And at that moment, I realized the need of develop better therapies for not only for pheochromocytomas and paragangliomas, because back then there was not FDA-approved agents, but also for neuroendocrine tumors. As we all know, in the last decade, there has been a lot of advancements for the management of neuroendocrine tumors. I think we are hopeful now because of a lot of experts in the field, but also the motivation that we have to develop better therapies for neuroendocrine tumors, including pheochromocytomas and paragangliomas, which is considered also a neuroendocrine tumor. But it was back then when I was practicing endocrinology that I felt that there was a need to develop better therapies. And with the guidance of Dr. Steve Liwoody, I decided to come back to the NIH, and I did a second fellowship and my institution is very supportive and very encouraging as well to study rare cancers and to be able to develop better therapies for these neuroendocrine tumors, including pheochromocytomas and paragangliomas. But this was a long answer, but the short answer to your question is that based on the need to develop better therapies, I wanted to dedicate my whole time, but also my life to develop better therapies for these tumors. And I hope in my lifetime, we can hopefully find a cure. That's my hope. I think everybody's hopes too.
We all hope the same. And thank you for seeing the need and stepping up and really doing something about it. It really makes those of us in the field who live with NET, and then I'm sure especially those who live with a rare type like Para and Pheo, feel seen. Thank you for helping people feel seen.
Thank you.
So again, we're just going to have a conversation about one of your favorite topics, paraganglioma and pheochromocytoma. So as we get started in this, I'm just wondering if you might just explain for the audience, who should be listening to this podcast episode? And do all NET patients need to know about Para and Pheo?
Yes, thank you so much for that question. And I think since this podcast is focusing on pheochromocytomas and paragangliomas, I do feel that patients that has the suspicious for this tumor type or is living with pheochromocytomas and paraganglioma should definitely listen to this podcast. Moreover, I have to also mention here that the LACNETs also had videos describing what pheochromocytomas and paragangliomas are, and also the management of advanced disease. So I will encourage, not because I'm there also in some of these videos, but also at the same time, I think the LACNES has wonderful information, libraries information that also mention about pheochromocytomas and paragangliomas, not only in English, but as well as in Spanish. I think it's important that patients that live with pheochromocytomas and paragangliomas can listen to the LACNES library. Moreover, we have the Pheo Para Alliance as well, who has a lot of information. It's dedicated also for pheochromocytomas and paragangliomas. Yeah, and also I have to say that since Pheos and Paras are neuroendocrine tumors, I just want to make sure that our audience are well educated, not only to learn about the disease, but also to educate others living with this disease as well. I think knowledge is power. So I think that this is important as well.
Knowledge is power. Well said. And yes, we just want to acknowledge that there are other resources out there, like you said, not only the videos that you did for us, but of course, Para-Pheo Alliance, who are our friends, and they have quite extensive resources, virtual conferences, support groups, and meetings to help those living with Para and Pheo. So if we might get into the first question, as we're trying to equip people with knowledge, which is power, what is paraganglioma and pheochromocytoma? Is it a type of cancer? And how common is it?
Yeah, thank you for that question. So let's just discuss what are pheochromocytomas and then paragangliomas. But overall, pheochromocytomas and paragangliomas, we sometimes call it Pheo Para or Para-Pheo to include both of those tumors. That the reality is the same. When we look under the microscope, is the same tumor type, it's just the location is different. Pheochromocytomas and paragangliomas are rare neuroendocrine tumors, and they produce an excess amount of a hormone called catecholamines or metanephrines. Pheochromocytoma forms in the adrenal medulla. So I always like to describe that the adrenal glands are on top of each kidney. And if we were to cut the adrenal gland in half, you have the outer layer of the adrenal gland that's called the adrenal cortex, but then the inner layer of the adrenal gland is the adrenal medulla, and that's where the pheochromocytomas form. Paragangliomas originates from nerves outside of the adrenal gland, and it could be anywhere from the head, chest, abdomen, and pelvis. But the reality is when you look under the microscope, is exactly the same. And another name for the paragangliomas are also called extra-adrenal pheochromocytoma, just because it's outside of the adrenal gland. Just a little bit more to describe as well between pheochromocytomas and paragangliomas. Most of the cases are pheochromocytomas, and about 80 to 85% are pheochromocytomas, but approximately 25% of these Pheos and Paras are paragangliomas. I also like to mention that there is, in terms of where it's located, they can be different type of paragangliomas. There are the paragangliomas that are located in the head and neck. I don't want to get too complex, but sometimes we call those parasympathetic paragangliomas. And the reason why we wanted to make a difference is because these head and neck paragangliomas most of the time are non-functional or non-secreting. That means that they don't produce hormones. And we can talk a little bit later about what the excess of hormone is and what symptoms they may cause related to the excess of hormones. But also we have the paragangliomas that are located anywhere from the chest, abdomen, and pelvis. Most of the time they are functional or secreting, meaning that they can produce excess of hormones and they can cause symptoms because of those hormones. Most pheochromocytomas and paragangliomas are functional as well. But I think it's important to differentiate in terms of where they're located and what is the difference between pheochromocytomas and paragangliomas that we discussed is mainly the location, whether they are in the adrenal gland or outside of the adrenal gland. We discussed that most common is the pheochromocytomas, about 80 to 85%, and we discussed that approximately 20% are paragangliomas. We also discussed that paragangliomas of the head and neck, most of the time they're not functional or not secretor. And then we have the paragangliomas located anywhere from the chest, abdomen, and pelvis. And they usually secrete catecholamines as well. The other question that you mentioned is that whether this is a cancer. And most pheochromocytomas are considered benign, which means that they are not cancer. And what that means, because I also like to discuss what does that mean by the definition of cancer. And cancer is a condition in which some of the cells may grow uncontrollable and they can spread to other parts of the body. And because of that, that's what we means that whether a pheochromocytoma is a cancer is when the pheochromocytoma spreads another part of the body. And that's usually the definition of cancer. But I have to mention that, as I said earlier, most pheochromocytomas and paragangliomas are benign, but approximately 10% of the pheochromocytomas can be malignant. And approximately 25% of paragangliomas can also be malignant. And we discussed malignant or cancer is because it can spread to other part of the body. So in terms of how common it is considered a very uncommon type of cancer, a rare cancer. So approximately, we say in terms of the statistics is that 2 to 8 people per every 1 million people are diagnosed with this tumor type. So we can see it's very rare. So anywhere from 2 to 8 per 1 million people may be diagnosed with this tumor type. So it's very, very rare based on the statistics.
Wow, thank you for that very thorough answer. So just like with all NED, it sounds like location matters. And it's really important where it's located. It really has a lot to do with everything else, the rest of the conversation you're going to be having. And in terms of benign versus malignant, that has to do with if it's spread, that would be malignant, versus if it's not spread, that would be considered benign. And so cancer is defined as if it's already metastasized.
Correct.
So what do you call it if it's not spread? Is it not a cancer?
So yes, so that's a very good question. So as I discussed earlier, what makes the definition of a malignant or cancer is because there are certain findings that are looked into the microscope that makes us believe that this could have a greater risk of metastases, but at the same time, when these tumors have the capacity to go to other places. So that's what we call malignant. And as I said earlier, most Pheos and Paras are considered benign, meaning that they are not, doesn't have any findings that maybe have a higher risk of malignancy. And I have to say that there are certain criteria, even though there has not been any score that has been validated in order to tell me whether these tumors has a risk of metastasis of no, but there are certain things that when you look under the microscope, whether there is any invasion or whether it is cells necrosis, when we look at it in the microscope, when the cells are many dead cells, whether also how the morphology is looking under the microscope, that kind of like make us understand whether these tumors may have a risk of metastasis or not. So paragangliomas, meaning the extraadrenal pheochromocytomas, a lot of these paragangliomas may be associated with a genetic mutation. In this situation, a succinate dehydrogenase mutation. Genetics are important in pheochromocytomas and paragangliomas, so that's the reason why every patient with pheochromocytomas and paragangliomas needs to be seen by a genetic counselor, because there is approximately 30 to 45% of these pheochromocytomas and paragangliomas are hereditary, meaning that they may have a germline pathogenic variant, meaning that they can be in every cell in the body. That's what germlines say, when there can be in every cell in your body, and you can then transfer that mutation if you were to have a kid. So there is a possibility that your kid may have that mutation, and when a patient have that mutation, may have the risk to develop tumors. So, and because of that, there is a mutation called succinate dehydrogenase mutation type B that has a higher risk of having a malignant behavior. So that's the reason why whenever there is a patient that have pheochromocytomas and paragangliomas, needs to be seen by genetic counselor to run a panel of what we call cancer predisposition syndromes, of genes that cause cancer predisposition syndrome, to then guide us what will be the follow-up for those patients, because what we're trying to prevent is that these tumors are diagnosed late, or they are having the appropriate follow-up and screening and surveillance scans prevent those tumors from going to other places. So I don't know if that answered the question. I think we talk about different aspects, so I just want to make sure that it's very clear to our audience what that means. And I think just to go back a little bit is that you asked the question about, whether if the pheochromocytoma is localized, whether it's malignant or whether it's going to other places. Is that the question that you asked earlier? I just want to make sure. Mm-hmm. So, and as I said earlier, most of pheochromocytomas and paragangliomas are benign. There is a small risk of these tumors to become malignant, meaning that they can metastasize. Now, one other aspect, we're still trying to learn if the patient has a pheochromocytoma and paraganglioma, who has the greater risk of metastases. And one of the risks that we mentioned is, for example, the size of the tumor. So if any paraganglioma that is more than 4 or 5 centimeters in size has a risk of metastases. The same with pheochromocytomas, which is an adrenal gland. The size is important, whether that could have a greater risk of metastases. Also, looking under the microscope, whether there is an invasion or any lymph node involvement, or whether there is any necrosis or cell death, that can also give me an idea whether they can metastasize as well. We discussed about the genetics. Succinate dehydrogenase mutation, especially SDHB, B as in boy, has a greater risk of metastasis as well.
Thank you for that. And that's a perfect segue. I know you already started answering questions about the genetic. Is it genetic? And who should get the genetic testing, which you said everyone should, and they would get the genetic predisposition panel. I'm curious, when should they get genetic testing if there's a certain time?
Yes, that's a very good question. So every patient, the minute that they are diagnosed with pheochromocytoma, or a family member who is diagnosed with this cancer predisposition syndromes, that's when they need to have genetic testing. Let me just go back a little bit here. So the question was like, who gets genetic testing? So, and as I say, every patient that is diagnosed with pheochromocytomas and paragangliomas needs to have genetic testing. Also, if there is a patient that had one of these genes associated with cancer predisposition syndrome, those patients also needs to go genetic testing as well. And the reason why, I don't know if this is the right opportunity to discuss about these different hereditary syndromes, but there are different hereditary syndromes associated with pheochromocytomas and paragangliomas. Just to mention a few, we have the multiple endocrine neoplasia, type 2A or type 2B. So the reason why is because type 2A versus type 2B, they have different clinical presentations. For example, the type 2A is associated with another neuroendocrine tumor of the thyroid gland, which is called medullary thyroid cancer. Also pheochromocytomas, mainly in the adrenal gland, rarely paragangliomas, meaning outside of the adrenal gland. And also the type 2A also have another, that's a benign tumor of the parathyroid gland, which is located in the thyroid gland. That's the reason why it's called parathyroid, and that gland is responsible to regulate your calcium in the body. So that's 2A. 2B, besides the medullary thyroid cancer and the pheochromocytoma, has a very specific physical findings that's called Marfanoid habitus, meaning they're very tall, lanky, sometimes the arms are bigger. So there are certain physical findings that are associated with multiple endocrine neoplasia type 2B. So whenever we see somebody, sometimes we see this type 2B that sometimes has not been diagnosed before, we call that de novo, but sometimes based on the clinical findings make us also suspicious of this type 2B. So the gene affected for either MEN2A or MEN2B is the red proto-oncogene. So we have other, for example, the neurofibromatosis type 1. So the gene associated with that is NF1. They also have a very specific tumor presentation, the NF1. They have the neurofibromatosis, meaning there are the skin findings too. They have the optic glioma, so there are certain tumors in the back of the eyes, as well as the caveolate spots. So there are certain characteristics with the NF1 that make us suspicious, and the gene affected is the NF1 gene. We also have other cancer predisposition syndrome. It's called von Hippel-Lindau. And von Hippel-Lindau also has a very specific tumor associated with von Hippel-Lindau, and the gene affected is the VHL gene. And we have the hereditary paragangliomas, and those are the succinate dehydrogenase mutation, either A, B, C, or D. Most common of those is either the B or the D. So I know that I say a lot right now, and I apologize for saying so much, but I think it's important just to summarize. Every patient that have pheochromocytomas and paragangliomas needs to have genetic counselor, and also needs to have a panel specific for pheochromocytomas and paragangliomas. And it's possible that, they may be sporadic, meaning that we don't know the cause of the Pheo Para, but we're able to diagnose one of these genes associated with pheochromocytomas and paragangliomas also can guide us what will be the follow-up, as well what kind of scans we need to do, what surveillance scans we need to do based on the cancer predisposition syndrome. There are guidelines as well and can help us determine what will be the follow-up. At the same time, if we find someone that has one of these mutations associated with the cancer predisposition syndromes, that can also guide us to test also family members of the kids. So that's the reason why it's so important.
Sounds like key information that we need to know, or that you need to know about your patients. Thank you. That's very helpful. And you also answered, which naturally would come up if family members should get tested or screened. Mm-hmm.
Yes, it's very important, and I just want to mention something. So because I think genetic counseling is important, and it can sometimes be a little bit confusing too, because it's always a patient that was diagnosed with Pheos and Paras. They usually ask me who needs to have genetic counseling, and all patients diagnosed with pheochromocytomas and paragangliomas needs to be referred to genetic counselor. We discussed that approximately 30 to 40% are hereditary. But also, once we know that the information can help us get surveillance in patients and their families, but also help us to establish the risk, to understand whether they can develop another pheochromocytomas or paragangliomas in other part of the body. It can also help us guide who may have a recurrence or a risk of metastases, and as well as I discussed earlier with the different cancer predisposition syndromes, help us to establish the risk of other tumor associated with that cancer predisposition syndrome.
Yeah, so key information that you need to guide so many things here in terms of the whole conversation, not just the treatment, but gives you a better picture of the landscape. So our next question is a very common one. What are the symptoms of para or pheo?
So we know that there are paragangliomas, for example, the head and neck that do not secrete any hormones. And then we have the paragangliomas, which can be localized anywhere from the chest, abdomen, or pelvis, as well as the pheochromocytomas. The majority of them produces hormone. And because they produce these hormones, they can also develop these symptoms. And just to let you know, the diagnosis of pheochromocytomas and paragangliomas, especially with symptoms, they also call it the great mimic, because it can have a series of symptoms and some of them may not be very specific. And because of that, some patients with pheochromocytomas or paragangliomas may be misdiagnosed. Sometimes they may have high blood pressure and they think like, well, maybe it's just any essential hypertension that can happen, or sometimes because of the palpitations or the feeling anxious, they may also be confused or having a depression or anxiety. So I think it's important that we explain what are the symptoms related to pheochromocytomas and paragangliomas. So some of them may be chronic. So these symptoms may be happening for some time.
It sounds very unfortunate and frustrating that they could be misdiagnosed for many years.
That's correct. And sometimes we have seen patients too that they may having all these symptoms for long periods of time, and they don't know that this could be a pheochromocytoma or a paraganglioma. By the time we see them here in our institution, they already have metastatic disease. So I think awareness about this tumor type, and as well increasing education that you can think about this tumor whenever we have these specific symptoms is important as well. And educate our healthcare providers that if somebody has these symptoms to think about the zebras, right? So that's what we talk about. And that also happened with other neuroendocrine tumors as well, that they're especially neuroendocrine tumors of the GI pancreas. They're sometimes over the years diagnosed with irritable bowel syndrome without thinking, what we can do next, right? And then get treatments and doesn't get better. So I think that that's important to acknowledge the different symptoms associated with this tumor type. We discussed about the high blood pressure. So is the high blood pressure is something that we've seen in patients with this excess of hormones. Also palpitations, meaning the heart rate is elevated.
So when you mention high blood pressure, how high is high? How high would make you think, oh, this might be a para or pheo?
That's a very, very, very good question, because these patients with a blood pressure, they can have very elevated blood pressure, meaning when the systolic blood pressure, that's the highest number, can be on the 180s, for example, it could be quite high. At the same time, we can also see fluctuations in the blood pressure as well, sometimes very high, and sometimes it goes very low, depending on the amount of hormones that the tumor is producing. And also sometimes in regards to the blood pressure, there are certain things, because these elevated blood pressure and the palpitations and the sweating, these episodes sometimes can happen several times during the day. And there may be certain things that can also precipitate what we call these pheo spells. Sometimes this crisis, because the blood pressure can sometimes go very, very high. And when sometimes it goes very high, sometimes, they can also cause bleeding in the brain. Sometimes it can be associated with some cardiovascular events like a heart attack. So I think it's important to understand too as well when the symptoms happen and what can also precipitate this exacerbation of symptoms. And I want to mention this because I think it's important to know that there are certain stress that can also precipitate this pheo spells or crisis. Sometimes some patients are diagnosed with a pheochromocytoma when they need to have a surgery for other unrelated issue. And then when they go to the OR trying to do the surgery, the blood pressure goes very, very high, or the anesthesia as well can precipitate those events as well. Also, there are other like pain as well, or trauma or severe stress. There are certain food as well or drinks that may also exacerbate some of these crises, like for example, cheese or bananas or even a high amount of caffeine. There are certain drugs, for example, that can precipitate this crisis. And one of them is, for example, the steroids as well. Sometimes we take steroids because of back pain. We have a car accident and sometimes we need to have steroids, and sometimes that can also precipitate this crisis as well. So I think that's also something that we need to keep in mind whenever that happens. Is like we need to then guide us like, oh, well, maybe this could be a pheochromocytomas and paragangliomas. And that's what, the question is like, when do we suspect there may be a Pheo Para? So signs and symptoms related to this hormone excess. Also, when there is an increased blood pressure, either by drugs, as we discussed, there are certain drugs, cocaine can also do that, amphetamines can also do that, or whether there is anesthesia or surgery, and that we see this elevated blood pressure. Whenever we see this variability in the blood pressure, either very high or very low, sometimes when we have someone that is very difficult to control blood pressure, and sometimes we see patients that they have like 4 or 5 different antihypertensive medication, and sometimes it's very difficult to control. That can also help us suspect that this could be a pheochromocytomas and paraganglioma. So there are certain things that we need to keep in mind, so that way we don't have this misdiagnosis as we unfortunately see in a lot of our patients.
Thank you for that very thorough answer. Just the awareness of what might be causing these hormonal symptoms, basically, right. And then blood pressure fluctuations as well. And as you called it, the great mimic, because it can be vague and easy to miss. So, I think it's very interesting, these blood pressure fluctuation, headache, dizziness, these are all vague symptoms. And you're mentioning that a lot of times this is found accidentally. Mm-hmm. Yeah, incidentally or accidentally.
Yeah. Okay.
So, speaking of symptoms, now kind of shifting to testing and screening. What scans should I get if I have Pero or Pheo? And is there a certain order to which the scan should be done?
Yes. Thank you for that. And first, we need to establish the diagnosis of pheochromocytomas and paraganglioma. And I think I mentioned earlier, right, when to suspect a patient with Pheo Para. We discussed about the signs and symptoms related of catecholamine excess. And something that I didn't mention earlier that I hope I take the opportunity to mention here is that we discussed about the blood pressure and the sweating and the palpitation, but there also can be other symptoms like anxiety, like pain on the chest, feeling very fatigued. Sometimes heat intolerance can be one of those symptoms, very rarely as well. Constipation, that's another one, because this excess of hormone can definitely as well cause constipation too. Sometimes changing in position as well. Can we see this variability on the blood pressure as well, weight loss as well? This excess of hormones can also impair your insulin production in the pancreas, and that means that sometimes we see this can cause diabetes. We see this very elevated blood glucose as well. Flushing is another one as well that we sometimes see with these patients. So we can see, there are a series of symptoms that can be associated with Pheo Para. So, and as I discussed earlier, first, how do we make the diagnosis of pheochromocytomas and paraganglioma when we have these various signs and symptoms? We discussed about the elevated blood pressure caused by certain events like surgery or anesthesia, or variability on the blood pressure. So another thing that when to suspect Pheo Para, when there is a personal family history associated with pheochromocytomas and paragangliomas. We discussed earlier about the different cancer predisposition syndrome. So, and with all those signs and symptoms that can help make us suspect about pheochromocytomas and paragangliomas, then we need to make the official diagnosis. So how? First, we need to do the biochemical evaluation. I think prior to doing a CT scan, sometimes I have to say that these Pheo Paras are diagnosed incidentally because for other reasons, they have a CT scans, they have an accident, and they need to have a CT scans. And that's when we see these findings as well. But it's important also to establish what we call the biochemical diagnosis. And that's usually with a blood test. And that's, we like to obtain the blood, what we call the metanephrin, and higher the normal amounts is a sign of pheochromocytomas and paragangliomas. Sometimes we do a 24-hour urine collection, so it can be a blood test or it could be a urine collection, 24-hour urine collection as well. But then once we have the biochemical diagnosis that is suggestive of pheochromocytomas and paragangliomas, then we need to do the scans, what kind of scans we need to do. So we usually recommend obtaining a CT scan or compute tomography scan, or it can also be an MRI or magnetic resonance imaging. And these are the type of scans that help us to obtain a detailed pictures of what is inside the body. Now, something that I want to mention is that for the head and neck, sometimes we prefer to obtain the MRI just because sometimes it's very more detailed, the MRI, and because the neck area, we have many structures in the neck, the MRI may be better for the head and neck paragangliomas. Also, if there is if somebody's pregnant and we suspect a pheochromocytomas and paragangliomas, MRI absolutely better because there is no radiation with the MRI. But a CT scan is also very helpful to help us diagnose the location. So whether it is a pheochromocytoma, whether it's a paragangliomas, CT scans, MRIs can also be very helpful.
Yeah. This is really helpful, right? Establishing the diagnosis. So you said first you start with biochemical evaluation. So I guess let's break that down. What labs should be done first before moving to the scans?
So there are either a plasma or a urine test. I hope I can explain this because sometimes I have that question, what is the difference between catecholamines versus metanephrine? And I hope I can explain it well to our audience. But if there is any further question, please go back and look at our Lackness video on pheochromocytomas and paragangliomas, because there is a figure there about what these different tests are. But let's just explain in terms of the hormonal evaluation of the tests specifically for pheochromocytomas and paragangliomas. So we have what we call the catecholamines, and the catecholamines is 3 hormones that are measured within the catecholamines. And the catecholamines consist of epinephrine, norepinephrine, and dopamine. Now, the other ones that we measure is the metanephrines. So just to let you know, the epinephrine is then metabolized to metanephrine, and the norepinephrine is metabolized to normetanephrine, and those are your metanephrines. So we have your catecholamines, and then you have your metanephrines. Now, metanephrines are the best test to do in the plasma. And the reason why is because your catecholamines, the half-life of catecholamines is shorter, and sometimes we can miss a pheochromocytoma if you only measure the catecholamines. So it's very important that we measure the metanephrines. Those are what we call the most sensitive scans, and those are the ones that we measure in the plasma. But we also have the 24-hour urine collection of the either catecholamines or metanephrines. And sometimes the 24-hour urine collection can detect, because as we discussed earlier, these pheos can be very episodic and sometimes may not be, when we see these episodes of the pheochromocytomas and paraganglioma, sometimes in occasions may not be measured on the blood, and sometimes we need to do a collection of 24 hours of urine, because that's throughout 24 hours, and sometimes they're able to also detect some of those spells, and sometimes that can give us a lot of information. But usually we start with the plasma because we think of the blood test, because we feel that that's the most sensitive test, and it's usually the plasma metanephrines. I hope I explained that, but if there is any question, I feel like you can also watch the Lackness videos, because there is a picture there about what means by catecholamines and metanephrines, and I hope you find it useful.
Yeah, thank you. And that is a beautiful slide to refer to. And then you were talking about scans, and predominantly either CT or MRI based on location, or if there's a possibility of pregnancy. So with the CT, is there a certain type of CT that should be done? As you know, I know with NET, there's certain types of CTs.
So a CT with contrast, that can definitely help us, gives a lot of information. Of course, if there is something suspicious in the liver, always MRI is better for the liver. Magnetic resonance imaging is always better for the liver, whether it is a GI pancreas, neuroendocrine tumors, or whether it's a pheochromocytoma. If we wanted to look at the liver, always MRI is better. But CT scans with contrast is always very, very good for the diagnosis of pheochromocytomas and paragangliomas. Sometimes there is a CT scan specifically for the adrenal gland, if it's only a localized adrenal mass, adrenal gland. Sometimes there is a specific dedicated CT scan of the adrenal gland, because sometimes, depending on once they inject the IV contrast, sometimes we need to understand what is a certain measurements within the CT scan with contrast. We call that the Hansfield units. And again, I'm sorry if I'm saying too much of the technicality, but sometimes there is specific scan of the adrenal glands that help us understand whether looks more benign or whether this looks more a pheochromocytoma or something or more of malignant. So the CT scans are important, but again, there's specific CT scan of the adrenal glands that help us differentiate whether this is benign versus not benign.
Thank you for that. So CT with IV contrast or MRI if it's in the liver or possibility of pregnancy, or CT dedicated adrenals. And what about any functional imaging?
Yeah, that's a very good question. And also, especially pheochromocytomas and paragangliomas, a type of tumors that they like to be imaged by functional imaging modalities. So when do we do a functional imaging modalities? And when I meant functional imaging modality is either a 64 copper dotted scan or 68 gallium dotted scan, or we also have the MIBG scan. So those are the type of functional imaging modalities. Here at the NIH, we have other functional imaging modalities that's called the F-DOPA scan, but that's considered research and is only here at the NIH. Commercially is always available either the dotted scan or the MIBG scan. And the reason why I'm saying this is because pheochromocytomas and paragangliomas, approximately 95% of these tumors may express the somatostatin receptors on the surface of the cell. And that's why dotted scan is becoming a very, very good scan of functional imaging study for this tumor type. So what is indication of a functional imaging studies is all paragangliomas, even if it's less than 4 or 5 centimeters in size. Any paragangliomas needs to have a functional imaging studies. And the reason why I'm saying that is because sometimes the paragangliomas can be in multiple places, especially the ones associated with the succinate dehydrogenase mutations. It can be in other places. So the functional imaging, like dotted scan, can be very, very helpful. Any pheochromocytoma that is greater than 5 centimeters in size is also an indication to do a functional imaging modalities, because size is important. The greater the tumor, the greater the risk of metastasis. Any patient that has a recurrent pheochromocytomas or paragangliomas needs to have a functional imaging studies, as well as any patient that had metastatic disease. It's important to do a functional imaging study because it helps us to do the complete staging of the tumor. And also any suspected as well pheochromocytomas or paragangliomas that doesn't have any symptoms too. And another scan is the MIBG scan, and we do that scan in patients with metastatic disease. And the reason why is because there is MIBG treatment. So the MIBG treatment was approved in 2018 for metastatic pheochromocytomas and paragangliomas. So we feel that there is a patient that may benefit from MIBG therapy. It's important to do an MIBG scan. Now, sometimes the question that I have, and I know because sometimes insurance is difficult to prove either in both MIBG or dotted scan, I think for staging, will prefer the dotted scan because that has a very good scan to stage, what we call a stage, to look to see what tumors we can find in the body. Sometimes not all pheochromocytomas and paragangliomas may be positive on MIBG scan. So that's the reason why I feel that dotted scan is the best functional imaging modality. Now, if we think about treatment, so I would say to do an MIBG scan because the MIBG therapy is the only treatment approved for pheochromocytomas and paragangliomas, but not all patients are positive on MIBG. Approximately 45% Pheos and Paras are positive on MIBG scan, whereas the majority of patients with pheochromocytomas and paragangliomas may be positive on dotted scan. But there are some of them that may not be, and that's why we need to use other scans, such as the glucose scans, the FDG PET scan, or even the F-DOPA scan. But I don't want to say that because it's really for research and it's not available and is not going to be approved by insurance.
Okay, so thanks for also explaining not just which scans, but the priorities if insurance is causing issues. And I'm wondering if it matters what order people get the scans. Like, do they need to start out with a CT and then get a dotted scan, or vice versa?
So I would just say, so once we have a patient that is diagnosed with Pheo Para, if it's localized on the CT scan, unless, like I say, all paragangliomas needs to have a functional imaging modalities because it can be in other places in the body. And unless the pheochromocytoma, meaning the tumor in the adrenal glands, is greater than 5 centimeters and such, just because we know that the greater the tumor, the greater the risk of going to other places. Maybe if this 3 or 4 centimeters, maybe that patient doesn't need dotted scan or MIBG scan. But any patient that have metastatic disease, all of them needs to have functional imaging modality after the CT scan. And my preference will be to start with a dotted scan, just because that is the most sensitive scan. Just to tell you some numbers, approximately 98 to 95% of Pheos and Paras can be seen on the dotted scans in terms of the number of tumors. So you can see that it's a very good scan. Whether MIBG is not all of them, like I said, 45 to 50% may be seen on the MIBG scan. But yes, I mean, I think any patient that we feel like may have metastatic disease, risk of metastatic disease, we need to have a functional imaging modality, like in this case, dotted scan.
Thank you for that. So now we have a diagnosis. We started the workup with labs and imaging. What's the treatment for para or Pheo?
So if it's localized, then we need to surgery in those situations. So whenever we has a localized pheochromocytoma, as I said earlier, most common in terms of the Pheo Paras is the pheochromocytomas in the adrenal gland. If it's localized, surgery is indicated. If it's sporadic, meaning that there is no any known cause of cancer predisposition syndrome associated with Pheo Para, after the tumor is resected, it's very important that we check the hormones after surgery, usually anywhere from 4 to 8 weeks after surgery. But I like to follow those patients every year for life because there is still a risk of recurrence. So that's important to know. Now, if there is a Paraganglioma, after repeating the hormonal evaluation after surgery, when it's localized, we resect it, right? So in those situations, I still like to follow the hormonal evaluation every 6 months, every 12 months. And in those situations, if it's a Paraganglioma or is associated with one of the cancer predisposition syndromes that we discussed, I like to obtain either a CT or MRI every 2 years, depending on what gene or mutation is associated with the pheochromocytomas and paragangliomas. And of course, if there is this Pheos and Paras is associated with either von Hippel-Lindau or NF1 or the MEN2A or B that we discussed earlier, there are certain imaging studies or protocols that is according to the guidelines per those cancer predisposition syndrome. So I know it's a long answer, but just to summarize, if it's localized, surgery. The issues when it's metastatic or when it's localized, but we're unable to resect. And that's when we need to discuss other therapies. And I don't know, Lisa, do you want to discuss the management here of metastatic disease? What do you want to discuss?
I think, if you just maybe share some of the options. And I think that the biggest questions are, how do I know how to get appropriate treatment? How do I get appropriate treatment? And how do I know what appropriate treatment is?
Right. So yes, that's a good question. Like I said earlier, once it's localized surgery, there is a specific follow-up for those patients. But once it's metastatic or it's locally, but is unable to resect it, that's when we need to understand what we need to do next and what my options are. Prior to that, I want to mention something that I didn't mention that is super, super important is any patient that is undergoing surgery or any patient that has metastatic disease that may require certain treatment, is important for those patients to have a medication with an alpha blockade, either doxazosin, phenoxymesamine, just to mention some of them. And the reason why every patient that is Pheo Para that is secreting needs to have this type of medications. Alpha blockers, sometimes they may need a beta blocker, such as propranolol, metoprolol, that's the other medications that they have. But this excess of hormones binds to some receptors on the blood vessels. So when there's this excess of hormones and going binds to the receptors in the blood vessel, that can cause what we call vasoconstrictions, and the blood pressure can go very, very high. So because of that, we need to give a medication that blocks those receptors so that way it doesn't cause the high blood pressure. And it's important because we discussed some of the risks of having this elevated blood pressure. But yes, it's important, very important. Every patient that is either undergoing surgery or they're going to have systemic therapies or any procedure with the diagnosis of Pheo Para that is secreting hormones, always alpha blockers, doxazosin, phenoxybenzaimine. Phenoxybenzaimine is very expensive. It's not widely available. Most common is doxazosin, prazosin, terazosin. Those are called disozins. And in some situations for the headaches and the high blood pressure too, adding a beta blocker sometimes can have a benefit, but it's always first of a blocker and then the beta blocker. Because if you give the beta blocker first and you don't know they have the diagnosis of pheochromocytomas or paragangliomas, that can definitely cause an elevation of the blood pressure. So now we discussed about the management to help block this hormone excess. We discussed alpha and beta blocker. Now, what do we do when it's locally advanced and we cannot do surgery, or when there are distant metastases? I think it's important to understand what treatment options we have. And in a subset of patients, I'm not saying all of them, but there may be some patients that may benefit for some surgical intervention or local therapies, even in the metastatic setting. But that's the reason why it needs to be discussed with a multidisciplinary team or a surgeon that is very familiar with this tumor type to understand what will be the benefit of resecting some of the tumor, even in the advanced metastatic setting, especially for the patients that secrete hormones. But in the setting of metastatic disease, meaning in different part of the body, what I like to understand as someone who treats this tumor type is whether it's slow growing or whether it's rapidly growing. So it's very important whenever I see a patient with pheochromocytomas and paragangliomas that is metastatic, I need to understand what is the disease growth, because based on that, it can guide me what will be the treatments that I will recommend. If we have a patient that is, the tumors are growing quite rapidly, it's a lot of tumors that I see in the body, and they're symptomatic because of that, maybe chemotherapy is what I would recommend. And there is a specific regimen that we recommend in those situations. And the regimen is with a chemotherapy with 3 different chemotherapy agents, cyclophosphamide, vincristine, and dacarbazine. Now, when it's low grade, moderate progression, either slow, moderate progressive disease, but it's still metastatic, first I need to determine whether, I can give other therapies. MIBG is a type of radiation therapy that can be a good option for those patients that have MIBG positive tumors, and also for those patients that the hormones are high and is causing these symptoms, because that's how it was initially approved. The MIBG treatment, it was approved because the patients that received treatment, they were able to decrease the blood pressure medication by 50%. And I think that's something that was very important, because the blood pressure got better and they decreased the amount of medications, the blood pressure medicine that these patients were receiving. And that's how the MIBG treatment was approved. And if the patient has MIBG positive tumors and they are secretors, that could be also a very good therapy. Now, sometimes the question that I get is like, when do we give Lutathera? Because Lutathera, we know, is approved for patients that have GI and pancreas neuroendocrine tumors. And it makes sense, if my tumor is positive on the DOTA scan, can I get Lutathera treatment? And it can. I have to say that it's an ongoing clinical study for Lutathera for the treatment of advanced metastatic pheochromocytomas and paragangliomas. Sometimes because it's not approved by the FDA for that indication, sometimes the insurance is difficulties approving for that, but we have a clinical study. I think it's important to consider participating in a clinical study. But there are other treatments as well in the metastatic setting, and we have those family of drugs called the tyrosine kinase inhibitors, and those are drugs that block the blood vessel supply going into the tumor. And because these tumors, they're very vascular, it makes sense to give one of those treatments. But that's something that we need to discuss with the physician who is treating you, what my options are and when to give it. I think it's important. Some of these tumors may not grow, and that's why we need to understand, and it's okay in those situations, and we just want to watch it just to see, how they're doing. I think what we call observation in some patients may still be beneficial. So I think, and I'm sorry, I think we discussed so many options, but just to summarize, I like to summarize. So it's alpha beta blockers. Those are the medications to block the hormone excess. Now we need to understand whether it's locally advanced, meaning the surgery may not be indicated, or distant metastases. We need to establish what is the growth rate, because it's rapidly growing and many tumors, chemotherapy may be the option. If it's growing but slow pace. So maybe we need to consider some of these radiopharmaceuticals that we call it, like Lutathera or MIBG. The MIBG is the only FDA-approved agent, Lutathera in the setting of clinical trials. We discuss other options like the tyrosine kinase. One thing to keep in mind is that sometimes this tyrosine kinase can increase the blood pressure, and that's what these medications do. So that's why it's even more important to make sure that we control your blood pressure with this medication that we discussed, the alpha beta blocker. And some patients may benefit from surgical intervention, even in the metastatic setting, but we need to discuss that with our surgeons and see what there is a benefit. It's not for everyone, but that's something that we need to discuss. And again, if it's not growing and it's not causing any symptoms, maybe observing may be an option. But I think those are the options that we need to discuss based on how the tumor is behaving, based on how many tumors we have in the body. And those are the things that we need to consider. And that's why sometimes I feel like these tumors need to be discussed in a multidisciplinary team or someone who has expertise on these tumors, because that can definitely help us understand, guide treatments based what is the growth rate, if the tumor is positive in MIBG or in the skin, how many tumors we have in the body, and what are the treatment options.
What an excellent overview, really explaining, well, this is not an easy decision. It's very complex. And as you said, you need a multidisciplinary team and a multidisciplinary approach to weigh in all these various factors, especially with metastatic disease, to see what is the best option. And of course, you're looking at a multi-pronged approach, both with the symptom management with the alpha blocking, and then also the tumor control with anything from watching and learning to chemo to Lutathera, PRRT, or oral agents. So many options out there. I think that's the takeaway, that there are many options. There's not just one or two. There are many possible options available, even with metastatic disease. And that's hopeful and encouraging. So the next question is, what if I had surgery and my disease recurs after surgery? What are treatment options then?
Yes, and that's why there is an indication, like if you have the tumor was resected and recur, that's also an indication to do a functional imaging studies to make sure we don't have any tumors any other place in the body. And we discuss in those situations, we like to use the DOTA scan, either the copper, 64 copper or the 60 gallium DOTA is the same. Sometimes the patient is like, what do I do? Which one is better? But it's the same. The same for other neuroendocrine tumors. It's the same. I would just say that whatever DOTA scan is in your facility or you can get, I think that's the answer. The two of them are equally the same in terms of how they're able to diagnose the tumors. But if it's recur, so we need to know where it recur, whether it recur in the area where the surgery was. Sometimes the reason why it recur is because sometimes there are, even after the surgery, so there may be some tissue left behind, sometimes because there is involvement of the lymph node. So that's why looking under the microscope, looking at the pathology findings is important, because if we know that there is some lymph node involvement, we know that there is an invasion in those areas where the surgery was, so the likelihood of recurrence is high. So first is to determine if it recurs, if it's localized, whether another surgery will be beneficial. So that's something that we need to discuss with our patients, whether any type of local therapies can be done if surgery is not an option and is still localized in one area. And then, of course, the functional imaging modality is very important to determine whether there is other part of the body, because when it's another part of the body, then we need to discuss the systemic therapies that we discussed earlier.
Yeah, so if it recurs and it's localized, surgery could be an option again. Correct. Okay, because that comes up frequently, right? Can I have surgery again? Or as you said, maybe other localized treatments. And then if it's spread based on functional imaging, then we go back to the options you mentioned previously.
Yes, that's correct.
Okay. So the next question is, after surgery, will my symptoms be gone? Well, after surgery or any other treatments, MIBG, Lutathera, anything.
So usually when it's localized and we resect all tumor, symptoms tends to go away because you remove the tumor that is producing the excess of hormones, and without this excess of hormones, you may not have the symptoms, right? We have seen this in our patient, they have all the symptoms like high blood pressure, the sweating, the heart, the palpitations, and that once the tumor is removed, the symptoms are gone. So that we have seen that. Now, when we have tumor in other places, metastatic, even if you do surgery, but if you have tumors in other places that may produce these hormones, it's possible that you may still have the symptoms associated with the pheochromocytomas and paragangliomas. So just to recap, yes, if the tumor is localized, we resect all the tumor, symptoms, yes, tends to get better. But if it's in other places, then symptoms may not necessarily go away. So that's why it's very important, the indications of when to do these CT scans or MRI, or the indications of when to do the functional imaging modalities to help us understand if there is any other tumors, any other part of the body.
Yeah, well, that's hopeful that hopefully the surgery or treatments would help people feel better. And so the last question, so, say I'm someone who has para or pheo, and I've been told I can't get a biopsy or that surgeries might be dangerous. Mm-hmm. What do I need to know and what do I need to do?
Yeah, that's a very good question. And that's the reason why your alpha and beta blockers are so important, especially for those tumors that are secreting the hormones, because that can help us control the symptoms related to the hormone excess. So if we suspect that a patient has pheochromocytomas and paragangliomas, and sometimes we have some difficulty controlling this hormone excess, we sometimes don't necessarily like to biopsy this tumor, because the minute that you start putting a needle, in the tumor, that can release these hormones. And with these hormones, we have all these symptoms. But if a biopsy is indicated, we need to make sure that the patient has adequate alpha blockade, as well as sometimes plus minus a beta blocker. So we need to make sure that the blood pressure is controlled under those medications before a biopsy is done. So that's very important, because we don't want a patient to have a biopsy and doesn't have the adequate blockade, because once you start putting a needle in the tumor and mobilize the tumor, that can definitely cause a release of hormones, and that release of hormones can definitely cause all the symptoms that we discussed earlier. So I think that's important, that prior to any surgery, that the patient is an adequate alpha blocker plus mono beta blocker, depending on what symptoms we need to control.
And just to clarify, how do we know if it's adequate blocking?
That's a very good question. So once do we know that? Because sometimes with this excess of hormones, we see these fluctuations in the blood pressure. So once I see that there is not that much fluctuation on the blood pressure, and sometimes my patients may say to me, like, oh, I was in the 90s and then on the 170s, and they tell me like, oh, it's more, stable. Well, I don't see that much fluctuation, and the medication helps to do that. Also, when we see those changes on the blood pressure with posture, we call that postural changes related to the blood pressure, that indicates like, well, maybe it's enough of an alpha blocker. In those situations, sometimes we recommend the patient to kind of like take extra salt in those situations. Or sometimes we give a salt tablets to avoid those postural, what we call hypotension, meaning that changes on the blood pressure when sitting. So I understand that sometimes it can be a little bit confusing, because sometimes they say, well, my blood pressure is high, so I cannot take any salt. But once you have adequate blockade and we don't see that much fluctuation on the blood pressure, and we see that there is some postural changes and the blood pressure, sometimes we can recommend the patient, okay, keep an eye. So we may need to give you a little bit of salt, so that way we don't see that much changes. Sometimes with the phenoxybenzamine, patients feel a little bit stuffed. They feel a little fatigue. Those are one of the side effects as well. Sometimes I need to keep an eye as well. But sometimes when we see that, it's like, okay, I think like you have adequate alpha blockade. But yes, that's an important question. So when do we see an adequate alpha blockade, and what to do once we feel that there is an adequate alpha blockade and we see these, what we call postural hypotension, meaning changes on the blood pressure with posture. So in those situations, we do recommend adding a little bit of salt, either in the diet or sometimes giving you salt tablets.
Yeah, it can be counterintuitive to take the salt tablets, but sometimes necessary, even though it's against what maybe you were initially told. So this has been a really thorough discussion and overview. And I'm wondering, as we close this podcast episode, what words of advice or encouragement do you have to the parapheo community?
Yes, I like to say this because before I decided to do a second fellowship in oncology, I think you asked earlier, like why I wanted to do this. And it's because more than 10 years ago, we didn't have options. We didn't have any approved agent for pheochromocytomas and paragangliomas. But I have to say in the last decade or so, we have seen some advancements, not only for the other neuroendocrine tumors, the GI and the pancreas, but we have seen a lot. We have learned so much about Pheo Para, not only from the genetic perspective, but we also from the imaging perspective, what kind of images we can do in those patients, what are the genes that has been discovered that has been associated with pheochromocytomas and paragangliomas that now help us now to understand more about the biology of these tumors to then develop treatments. So initially, when I start seeing patients with neuroendocrine tumors for Pheos and Paras, there were not that many treatments. Being a rare cancer, sometimes it has been very difficult to do studies. But now I have to say that I feel hopeful because we now understand more about the biology of these tumors. Now, because of that, we are now able to kind of like develop therapies and the end of clinical trials. Like, for example, the Sultifan was recently approved for VHL, von Hippel-Lindau-related tumors, and we feel that that can also be a good option for pheochromocytomas and paragangliomas. And there is an ongoing national study with the Sultifan for these patients as well. I'm very fortunate as well that I'm the national co-chair together with Dr. Perez from Dana-Farber for a treatment for pheochromocytomas and paragangliomas with another chemotherapy, oral chemotherapy called temozolomide. And it's a study that either patients receive temozolomide or they get temozolomide in combination with olaparib, because we feel that our hypothesis by adding olaparib, temozolomide can be more effective. And there are ongoing studies with the tyrosine kinase that I discussed earlier with exitinib. Dr. Fojo at Columbia University has a study of cabozantinib, Dr. Jimenez and MD Anderson has a study. I think that I have to say for our Pheo Para community, I'm feeling very hopeful. We're learning so much about this tumor type. I think there are ongoing treatment studies that can definitely help these tumors, not only shrink the tumors, but also destabilize these tumors for long term. I want my patients to feel hopeful because I know that we have better treatments, more treatments, and that's because of you. That's because of the patients. We're learning from the patients. I always tell my fellows, our patients are that's when we learn the most. It's not all about books or what we learn in books. It's our patients that we learn the most. And by listening to our patients, we can understand more about the disease. We can then develop guidelines for those patients. And of course, awareness too. I think increased awareness of these tumors can definitely help us not only understand, but also detect those tumors earlier. So I have to say, I'm very hopeful. We're very excited here that we have, together with Dr. Carl Patzak, a pheochromocytomas and paragangliomas therapeutic programs with natural history study that help us see patients long-term, but at the same time, treatment studies here at the NIH. So we are excited about that.
There are many reasons to hope, and thank you for being part of that reason, because there wouldn't be this many advances and clinical trials and better understanding and awareness if it weren't for people like you who are so interested and dedicated to this field. So thank you for all you're doing for the field of parapheo, for NET in general, for cancer, and for all of us. From the bottom of our heart, thank you so much.
Thank you for having me here. Thank you. Thank you.